Everyone. I am going to discuss about evolving evidences in first-line recurrent metastatic squamous cell head and neck carcinoma. We'll talk about the landmark clinical trials, and we will also have some data about real-world evidences from Indian population database. We all know about the demography of head and neck cancer, that India leads the world in head and neck cancers, and most of lip and oral cavity cancers are most common. Around 1/3 of the lip and oral cavity cancers of the world are present in India, and it causes about India contributes about 40% of the mortality in lip and oral cavity cancers worldwide. If it, we have already discussed about the tumor characteristics that the majority of the patients do present in advanced stage, that is stage 3 or stage 4, and this tumor data from Tata presents that a median age of diagnosis was from 50 to 54 years. Coming to the key clinical trial data, we will discuss in brief about the data of chemotherapy with target therapy, that is cetuximab, immunotherapy data in first line recurrent metastatic setting, and data of metronomic chemotherapy from TMH. Coming to the target therapy data, basically we all know that extreme data which we have been using platinum based doublet with cetuximab in first line since almost a decade. Platinum based chemotherapy was previously used doublet before introduction of target therapy cetuximab, but in extreme trial we had platinum based doublet, that is cisplatin plus infusional 5FU, which was compared with platinum based doublet plus cetuximab followed by cetuximab maintenance until progression. Primary endpoint of this trial was overall survival. It was a randomized phase 3 trial, and if we see the 5-year follow-up data, in intent to treat population, median OS was significantly improved in the cetuximab group, 10 months median OS as compared to 7.4 months median OS in only in the chemotherapy doublet arm. Hazard ratio was 0.8, that is 20% decrease in death with cetuximab arm. If we see subgroup analysis of patients with oral cavity, median OS was drastically improved with cetuximab arm, 11 months as compared to 4.4 months. However, the problem with this extreme arm was infusional 5FU, which added to the toxicities as well as stay, especially for a palliative setting. So there was a phase 2 trial which compared platinum plus taxane, that is docetaxel, as compared to extreme arm. So in this trial, basically there were comparison between cetuximab plus platinum plus 5FU as compared to cetuximab plus platinum plus taxane. The difference was that in TP extreme, 4 cycles of chemotherapy were used as compared to 6 cycles in extreme arm. Cetuximab maintenance was given 2 weekly as compared to weekly in extreme arm, and doses of cisplatin were reduced to 75 mg per meter square as compared to 100 mg per meter square. If we see, it was a non-inferiority trial, so overall response rate were similar in both the arms. Rate of progressive disease favored TP extreme group, and median OS also favored TP extreme group. And if we see comparison of TP extreme with extreme, we know that TP extreme was a better arm, as it was a single day taxane infusion as compared to 4 days 5 infusion of extreme. Grade 3 onwards AEs were less in TP extreme group. Chemotherapy exposure cumulative was less. Percentage of patients who were able to complete the planned number of cycles was more, 72% as compared to 44%, and maintenance cetuximab was also more compliant bi-weekly as compared to weekly. So from this, usually we have been shifting our practice in majority of our patients to TP extreme as compared to extreme. If we see immunotherapy in last 4 or 5 years, immunotherapy has also been revolutionizing treatment in head and neck cancer, especially in the first line setting. This data has come recently since last 2 or 3 years, and pembrolizumab plus or minus chemotherapy was used in Keynote 048 trial. It was a randomized phase 3 study in which patients were randomized into 3 arms, that is pembrolizumab monotherapy versus pembrolizumab plus chemotherapy, that is platinum plus 5FU, infusional 5FU, and the third arm was extreme arm. Patients were also stratified according to PD-L1 expression, and pre-planned analysis was done depending on PD-L1 score. We see about pembrolizumab monotherapy group. Pembrolizumab monotherapy has not shown superior OS as compared to extreme in intent to treat population. However, when we compared subgroups of CPS score more than 1 and more than 20, subgroups pembrolizumab monotherapy fared superior. We can see the OS curves wide apart, especially in the subgroup of CPS more than 20. The problem being that subset analysis was done in CPS group more than 1. So this included patients of subset more than 1 as well as more than 20. So these data might be complicated by including CPS score more than 20. I would like to have a subgroup analysis in the form of CPS score 0, CPS score 1 to 20, and CPS score more than 20. And this data would have been interesting to see. If you talk about pembrolizumab plus chemotherapy arm as compared to extreme arm, pembrolizumab plus chemotherapy arm definitely wins in intent to treat population, as well as in patients with CPS score more than 1, as well as CPS score more than 20 subgroup. But we see in intent to treat population, the median OS was 13 months as compared to 10.7 months. There was a significant difference, but again, this intent to treat population included patients with CPS score more than 1 and more than 20. We don't have direct pre-planned subset analysis of patients who are PD-L1 negative. So it would have been interesting if patients with PD-L1 negative would have been studied in pre-planned manner. But it's again an overall intent to treat population showed OS benefit in all the arms. The problem with pembrolizumab, especially pembrolizumab monotherapy arm, was progression and hyperprogression. Progression and hyperprogression was seen in around 40 to 45% of the patients, and hyperprogression, in fact, per se, was seen in 1/3 of the patients. So that was the concern with the pembrolizumab arm. Otherwise, it was well tolerated except some immune-related adverse events. We won't go in much detail of immunotherapy as second line, but just to touch it, that we have few subsets, those who have already received platinum either in curative setting as induction therapy and have progressed on it, or those who have received definitive chemoradiation with platinum-based therapy, concurrent therapy, and they have progressed in within 6 months. So such patients would ideally be candidate for first-line recurrent metastatic setting, and so such patients would be eligible for monotherapy of nivolumab or pembrolizumab based on checkmate 141 as already discussed by my colleague Dr. Rushabh, and even keynote 05 trial which proved that such patients can also be offered pembrolizumab. Median OS in such studies was in the range of 7.5 to 8 months, and response rates were in the tune of 15 to 17% with immunotherapy as compared to 5 to 6% response rate with investigator choice. Coming to the real world scenario in India, we know that majority of our patients don't have deep pockets and they can't afford immunotherapy or target therapy. So this study of oral metronomic chemotherapy, low dose, low cost oral metronomic chemotherapy versus IV cisplatin was performed by TMH group. It was an open label, non-inferiority randomized phase 3 trial, and this had a promising data with less toxicity. I would just brief you about this study. This was a randomized phase 3 study, open label, non-inferiority trial, in which patients were randomized to single agent cisplatin 75 mg per meter square 3 weekly, that is platinum singlet. As we know that singlet or doublet does not improve much survival, just it increases the response rate. And other arm was oral metronomic doublet, that is MTX plus celecoxib given in standard doses. And primary endpoint was OS. If we see the OS data, again, median OS for cisplatin arm was 6.1 months, while for metronomic arm it was 7.5 months with significant p-value. And at 6 months, we can see that metronomic arm fared better, and even for superiority, p-value was significant for metronomic arm. If we talk about median PFS, again, metronomic arm wins over cisplatin arm, and even for superiority, p-value was drastically improved. And response rate was also around 13% metronomic arm as compared to 10% with cisplatin arm. So we can say that oral metronomic is also a cheaper option for those patients who cannot afford target therapy or immunotherapy. But obviously, median OS was in the range of around 7 to 8 months, and not as compared to target therapy or immunotherapy arm. but still it fared well as compared to chemotherapy arm. Especially those patients who are not fit for chemotherapy, those patients can also be offered oral metronomic therapy. We should say that most of this data comes from Western world, and Indian population differs, especially in head and neck malignancy as compared to Western world. So we had one article in which there was data of retrospective data of palliative chemotherapy with or without cetuximab in first line setting of metastatic or recurrent head and neck squamous cell carcinoma by Dr. Oncowin et al. This study total number of patients was around 229, and 140 patients received chemotherapy with Erbitux, and 89 patients received chemotherapy alone. Primary objective was to study response rate, PFS, and OS with safety data. We can say that in the patients who received cetuximab, majority of the patients received cetuximab with platinum-based doublet, and in chemotherapy arm also majority of the patients received platinum-based doublet, while other options were around, other regimens were around 10 to 15% of the patients in both the arms. To talk about oral survival, median OS in target therapy cetuximab arm was around 11.8 months, which matches well with the extreme or TP extreme data, and with chemotherapy arm alone it was around 8 months. Median PFS was again favoring cetuximab arm, 8 months as compared to 1 month with chemotherapy arm. Overall response rate was significantly higher in cetuximab group, and it was around 77% as compared to 45% with chemotherapy only arm. Talk about adverse events, cetuximab was fairly tolerated, and addition of cetuximab slightly increased skin reactions, but these were fairly manageable. I can conclude that adding cetuximab to chemotherapy improved overall response rate, PFS, as well as OS in Indian population with recurrent metastatic squamous cell carcinoma of head and neck, and cetuximab was well tolerated in our Indian population also. But to take this data with a pinch of salt, as this is a retrospective analysis and it is not a randomized data. This is just an interesting slide which just briefs how to select the correct first line option in recurrent metastatic head and neck cancer. We are going to discuss in detail next panel discussion about it, but depending upon the biological age of the patient, performance of the patient, tumor burden, the pace of the disease, and also most importantly PD-L1 CPS score, we need to determine our treatment of choice, whether it is to be chemotherapy with target therapy or chemotherapy with pembrolizumab or only pembrolizumab. Hope we will have an interesting discussion in the next panel. I'm not going into detail just because of shortage of time. I would like to conclude that PP extreme regimen showed similar overall response rate, OS, and rate of progressive diseases compared to extreme arm. Pembrolizumab plus chemotherapy has definitely shown OS advantage for extreme in overall intent to treat population, and specifically in patients with CPS score more than 20 and also in CPS score more than 1, but difficult to comment on patients with CPS score 0. However, there is a concern of rapid rate of progression when we use immunotherapy, especially as a monotherapy. Metronomic chemotherapy again shows promising results in human population, and especially for patients with poor performance or those who can't afford immunotherapy or target therapy. Nivolumab has shown superiority over investigated choice in second line or platinum refractory first line squamous cell head and neck carcinoma, and we have real world evidence from Indian population to support cetuximab plus chemotherapy, and I would like to see the long term data of pembrolizumab with or without chemotherapy as a survival tail, and specifically in Indian population it would be interesting to see the data of immunotherapy. I would like to conclude here. Thank you.
That was a very enlightening talk by Dr. Itesh Khatwani on the recurrent metastatic head neck cancers. And now I would like to call up